pitfalls here, and there's a lot of new information and new research that's being done on vascular tumors. So I think it's an area that is really worth discussing for people that do skin pathology. So, and my mentor, Dr. Weiss, had a great interest in vascular tumors, and many of the entities that we know about today were actually initially described by her, or she wrote the landmark papers on. So I think I inherited some of that interest from her. So let's go forward. I think what we'll do is we'll talk about kind of a general overview of how vascular tumors are classified. We'll talk about some updates and then also some diagnostic pitfalls that are really important to know about so that we can avoid trouble when making diagnoses of these lesions. So the basic classification is that benign vascular lesions are kind of into two categories: hemangiomas, which are actually proliferations of endothelial cells, and then vascular malformations, which are usually congenital lesions that are due to abnormal formation of vessels during embryogenesis. And we're not going to talk too much about these because I think that they're not quite as controversial as some of the other things. And then there are a wide variety of different hemangiomas and malformations that you probably are all somewhat familiar with. And then there are the malignant vascular lesions like Kaposiform and Angiosarcoma. We'll talk about that. And then finally, there is this kind of gray zone group, those vascular tumors that have intermediate malignant potential or intermediate behavior. They're not totally benign, but they're not as aggressive or malignant necessarily as, say, angiosarcoma. So because of that, we have them kind of in this intermediate category called Hemangioendothelioma. I'm trying to get the, I see that there's a message on chat, I'm sorry, but oh there, okay. I'm trying to pull it up, okay. So the Hemangioendotheliomas are this kind of gray zone group. And there are a wide variety of Hemangioendotheliomas, about 5 or 6 of them, and we'll talk about a couple of these later. And it's important to note that this is not one type of tumor with multiple histologic subtypes. Each of these Hemangioendotheliomas are totally distinct and more or less unrelated entities, and we'll talk about that in a minute. They're all very different clinically. They're different in how they behave. Everything about them is different. So it's important to understand that this is not like a wastebasket category for vascular lesions that you don't know what to do with. These are very specific, well-defined entities, and we need to be careful to maintain that, that kind of purity when we diagnose them. And then more recently, people have proposed that maybe, I'm going to try to go forward here, that maybe Kaposiform doesn't belong under malignant. Maybe it's more like an intermediate behavior lesion, and I think that makes sense. Most people do not die from Kaposiform. In contrast, most people with angiosarcoma will die from their disease. About 80% of people with angiosarc will eventually die from disease. And Kaposi, unless it's HIV associated, usually does not result in mortality. So maybe it's more like an intermediate behavior lesion. And if you take one of the Hemangioendotheliomas, Epithelioid Hemangioendothelioma, it probably belongs in the malignant category because fairly often, especially when it's a deep lesion in the lung or the liver, many of those patients actually end up dying from their disease. It's not as bad as angiosarcoma, but it's certainly much more aggressive than the other Hemangioendotheliomas. So why are vascular tumors so difficult to diagnose sometimes? Well, I think there is a handful of reasons. Number one, there are lots of different subtypes and lots of name variations. As with everything dermatology related, you can find 10 different names for the same entity in the literature. And that's because people like me, we need to get published, right? So we just describe the same lesion under a new name, and that's how we get papers published. I'm partly joking, but I think we all recognize that the literature gets kind of muddied because everyone names lesions so differently. But I think that's challenging. And then also on a clinical level, many of these vascular lesions look similar. They look like a red raised lesion or a purple violaceous raised lesion. And so that complicates things a bit. Microscopically, clinically, you can confuse vascular lesions with non-vascular lesions. I see sometimes hemangiomas or different vascular things sent in where the clinician thought maybe it was a pigmented lesion, like a melanocytic lesion or a melanoma. Hemangiomas sometimes can look malignant microscopically, and occasionally angiosarcomas can mimic benign lesions if you don't have a good biopsy. Sometimes you can have an angiosarc that's very subtle and looks benign. And also angiosarcoma can mimic other types of cancer. I actually had a case just very recently like that where it looked like a carcinoma and it was actually an angiosarcoma. And it's a huge difference for prognosis and treatment. And finally, immunostains and ancillary tests, while they can be helpful sometimes, there's a lot of times where extra testing or staining doesn't really help you. You just have to look at the lesion and decide if it's benign or malignant. And that can be very challenging. All right, so we'll talk about both updates and pitfalls. And the highlights that we're going to talk about during this hour is I want to focus on angiosarcoma, this kind of newer entity called atypical vascular lesion, or AVL, epithelioid hemangioendothelioma, this other entity with a really long name, which is epithelioid sarcoma-like hemangioendothelioma, and then we'll talk briefly about a couple of tricky hemangiomas that often confuse people. So angiosarcoma is usually in the skin or subcutis. Most of the time it's superficial and it's on the skin. So it's a very important lesion for dermatologists and dermatopathologists to know about. And it typically occurs, the most common place that I see it is on the head and neck of sun-damaged elderly patients, often light-skinned or white patients. And here in Arkansas, where I live, a large portion of the population is elderly and white, and there's lots and lots of sun exposure here, people that have worked out on the fields or in the farm their whole life. And so many of them have extensive sun damage, and I end up seeing angiosarcoma in that setting. But another very important setting is that of kind of iatrogenic angiosarcoma. That is angiosarcoma that arises secondary to radiation therapy, particularly in the breast for breast-sparing surgery for breast cancer, and also in the setting of chronic lymphedema, you can get angiosarcoma. So those are very important settings. And it can also occur in deep soft tissue rarely, and also in the internal organs, in the right atrium, which is a classic place for angiosarcoma. It's very rare, but if you see a right atrial mass, it's angiosarcoma until proven otherwise. And then the liver and spleen at the site of vascular grafts, those are some different places. I actually saw a splenic angiosarcoma very recently. And young patients and kids, I used to teach people that young patients never get angiosarcoma. But as we often know, that whenever you say never in medicine, you'll usually be proven wrong eventually. And I've now met a few young patients and kids through, I work with an angiosarcoma support group on Facebook, a patient support group. And I've met some people that were quite young, including a guy who's my age that has angiosarcoma. So you can have it, but you should be very, very, very cautious. And I would argue maybe even get expert consultation always before making a diagnosis of angiosarc in a very young patient or a child. I would probably still send a case to another expert to see before making a diagnosis in a child, just because it's that rare. All right, so clinically, angiosarcoma, when it's advanced, is very distinct. It is large, multiple nodules or plaques, and they're often black or violaceous or red. And you can see, looking at this, there's no doubt that's a malignancy. Here's one in a post-radiation site on the breast, and you can see it's multinodular. In the background, there's areas of bruising or ecchymotic areas. And here's one on an amputated leg from a patient who had a chronic lymphedema. And so here, it's not quite so nodular, but it's much more ulcerated, and there's a lot of erythema around it. It's very infiltrated. If you feel it grossly, you can feel its infiltrative skin and kind of firm to the touch. So microscopically, here's what an excision of angiosarcoma looks like. And when you have this kind of specimen, the diagnosis is not very challenging. When you have a tiny biopsy, of course, it can be a lot more tricky. Here you can see big nodules of tumor down in the deep dermis, and also some kind of infiltrating tumor up in the superficial dermis and off to the sides. And going closer, this is the classic appearance, these infiltrated, connecting, ramifying vascular channels, and they're dissecting in between the dermal collagen bundles. And if we go in for a closer look, you can see that the vascular channels are lined by markedly atypical endothelial cells. They have very hyperchromatic nuclei, and they have a tendency to begin to multi-layer or pile on top of one another. Vascular spaces are supposed to be lined by one layer of endothelium only. And when you start to have multi-layering of the endothelial cells, coupled with infiltrative growth like this, you must be very, very concerned for angiosarcoma. But sometimes the angiosarc looks like this, and you can see that these endothelial cells do not look very atypical, but the vascular channels are quite infiltrative here, and that's something to give you concern. But you have to use a little bit of caution, because sometimes hemangiomas and vascular lesions or even vascular malformations can have the appearance of infiltrative growth like this. So you have to be very cautious, and you have to use the clinical context and some other clues to help you. So here, when I look, you can see that the individual collagen bundles are wrapped completely by endothelial cells. That's a very worrisome feature for angiosarcoma. Kaposi sarcoma, which we won't really talk about much today, it also can do that. And so it's important to know that and to distinguish angiosarc from Kaposi. Usually the clinical setting can help you there, and HHV8 immunostain as well. So looking though at that same, when we go up to lower power on this same case, what you can see is these infiltrating channels, even though they look kind of almost cavernous and very bland, look where they are. This is normal breast ductal elements. And you can see that these channels are infiltrating all the way down into the breast parenchyma. And of course, this is a post-radiation patient for a breast cancer. And so this is an angiosarcoma infiltrating the breast. It's very well differentiated appearing. And so these can be quite tricky to diagnose, especially on small biopsy. All right, so let's take a closer look. You can see that the endothelium is beginning to kind of multi-layer a little bit. They're kind of getting clumps and clusters of endothelial cells, and that's a helpful clue. Here's another picture also. See the multi-layering of endothelium? That's a very useful clue for angiosarcoma. So even though there's not terribly prominent atypia, there's infiltration and there's multi-layering, and both of those things are important clues to the diagnosis. And this is the same case again, and look, this area here has the kind of well-differentiated, bland look that I was just showing you, and you can see over here as well. But look at this large nodule. When you go closer to that, you can see that that well-differentiated appearance is transitioning into very cellular, very nasty, high-grade looking angiosarcoma. So you can have a variety of patterns even within the same lesion. And here's another case of angiosarc, and when you just look at this power, there's no blood-filled spaces, there is no hemorrhage, there's nothing here to suggest that this is angiosarc. Even though I took this picture, if you showed this to me in outside of this lecture, I might look at this and say, oh, that's undifferentiated pleomorphic sarcoma, or what used to be called MFH. It doesn't look like angiosarc here. So I think the take-home is that angiosarcs can sometimes have solid cellular areas, but usually when you look around, if you have a large enough biopsy, if you look out to the periphery, you'll find some areas of more classic angiosarc. I've never seen an angiosarc that looked completely like this, but I have seen cellular solid areas in many cases of angiosarc. It's usually a relatively focal finding, though. You can find the vascular channel formation out at the edges. So I think, though, anytime you have a kind of epithelioid, funny-looking tumor and you can't quite classify it, always consider doing a vascular marker, because sometimes the angiosarc can be deceptive. So here's a case that's much more cellular and atypical, and you can see, though, that there are some extravasated red cells out here, and there are some vascular channels. So even though there are other areas that are solid, like I just showed you, you can see vascular channel formation. And look there, very infiltrative vascular channels, markedly atypical endothelial cells with huge nucleoli. Very useful clues. And the cytoplasm of angiosarc, particularly when it becomes epithelioid angiosarc, is often this kind of grayish blue or purple, this amphiphilic cytoplasm. So anytime you see a tumor with amphiphilic cytoplasm that looks malignant, always think about angiosarcoma and consider doing a vascular stain. So an update that's of interest is that several years ago, Thomas Menzel and his group, they described the presence of a c-Myc amplification, not translocation, but amplification in the setting of post-radiation and post-lymphedema angiosarcomas. So sun-damaged typical angiosarc on the sun-damaged skin usually is negative for c-Myc, but post-radiation and post-lymphedema angiosarc often has amplification of c-Myc. So this is a very curious and interesting finding, and diagnostically can be useful. You can use FISH to detect c-Myc amplification. So in the setting of post-radiation, where you often have unusual vascular changes that are just benign, and sometimes on a small biopsy it can be quite hard to tell if there's angiosarcoma or not, you can utilize c-Myc FISH to try to help you. And oh, I just explained all that. Sorry, I looked through these slides before, but sometimes I get ahead of myself. So it's a very sensitive and specific marker for angiosarcoma compared to benign vascular lesions. And here's an example this is a figure from Menzel's paper. On the right, you can see your negative control, 2 copies of MYC, as you would expect every normal cell in the body to have. But here, the angiosarcoma cell has multiple additional copies of the MYC gene. So it's a similar concept to how HER2/neu is amplified in breast cancer, or MDM2 is amplified in well-differentiated liposarc. It's that same kind of pattern where you have multiple additional probes staining compared to normal. All right, so angiosarcoma, as I mentioned earlier, is a grave prognosis. Many of the patients will die within less than 12 months of diagnosis, and the majority of patients will eventually die. So it's a terrible diagnosis, and because of this, we have to be careful to never give this diagnosis lightly, always be totally sure. And I know we always try to do that as pathologists, but if I'm wrong about saying something's squamous cell carcinoma or not, probably the patient is not going to die because of my mistake. If I'm wrong about saying whether or not something is angiosarcoma, that's going to be an enormous difference for the patient in their treatment and in their prognosis. And usually these are aggressively treated with surgery. Chemo and radiation are used sometimes, but not usually with great success. And the problem is that even when you do aggressive surgery, it's very common to have recurrence, and that's because these are blood vessel tumors. They have access to the vasculature from their inception. So from when the tumor arises, it automatically is able to invade the vasculature and spread. And so it's very easy for this tumor to recur locally as satellite lesions. It's easy for it to metastasize distantly. And like most sarcomas, distant metastases often end up in the lungs. So it's a terrible tumor. And through my involvement in that Facebook group I told you about, I have had the opportunity to meet many patients with angiosarcoma, and many of them have very kindly shared their pictures with me in order that I can help educate other doctors like we're doing right now. And so this is a picture that is really, the next picture I'm going to show you is very disturbing, I think, but it also really hits home to me the seriousness of angiosarc. And I've become good friends with this lady who unfortunately has passed away. Now her husband and I are good friends now through social media. And I'm actually going to get a chance to meet him in person this summer, and it's really touched my heart a lot to work with these patients and to watch them suffer so much, but also to watch how much they really want to help educate others about their disease. And it's really given me a drive to do more with my teaching and my research for vascular tumors. So here you can see this infiltrated mottled appearance of the skin and the ear. This is about 2 years after the initial diagnosis of angiosarc, and 2 years after that, this is what happened. The entire side of this poor lady's face was completely destroyed by the tumor, and then she passed away about a month after this. So that, I think, is the picture to always remember. This is what angiosarcoma does to people. It is a terrible, terrible tumor, and we should always treat it with the grave seriousness that it deserves. So there was a study a few years ago where sorafenib, a tyrosine kinase inhibitor, was used to treat angiosarc, and a couple of cases showed very dramatic response. And this was on the cover of Archives of Dermatology in 2012. And you can see this unbelievable response. The left, the entire face of this poor lady is infiltrated with the angiosarc, and on the right, after sorafenib, it looks like almost complete regression. The problem is that even though the effect is dramatic, it's not long-lived. This patient recurred and died, I think, within a year after this therapy, if I recall. So it's unfortunate that we still have a long way to go before we find a good cure for this disease. So we'll talk briefly about the pitfalls. Clinically, there are a variety of pitfalls that we need to know about with angiosarc. It can look a lot like a bruise or solar purpura because elderly sun-damaged people tend to get bruised patches on their skin. So if you see an area that looks like a bruise or solar purpura that's not going away, or that's ulcerating, or that's getting thicker, you should consider doing a biopsy to make sure it's not angiosarc. A small biopsy, of course, may not be representative. We always know that this is a problem with pathology that we run into. So I think that what I tell to the dermatologist, though, is that if a small biopsy comes back as a benign vascular thing, but if you clinically are very worried about something being angiosarc, you need to repeat the biopsy. Don't just trust that it's negative just because that small biopsy looked negative to the pathologist. And you need to talk to your pathologist, of course. I think I'm probably preaching to the choir here. Most of you know how important it is for the pathologist and the dermatologist to talk. But I think anytime the path report doesn't fit the clinical, but especially with vascular lesions, talking to the pathologist is important. I think another thing that clinically in dermatology we're probably not doing as well as we should is we're not educating patients about the need to examine their radiation sites or examine their areas with lymphedema for any changes that could look like angiosarc. I don't think we necessarily need to tell every patient, hey, there's a risk you're going to get a deadly vascular tumor. You know, I don't think we need to raise excessive worry. Most patients with radiation do not get angiosarcoma. It's relatively rare, but I think it's good for us to let people know if they see changes in their skin at the radiation site, they should get an appointment and see their dermatologist immediately. So, and I think also most dermatologists, when I ask them, do you examine your patient's radiation sites on your general skin exam? Most of the answers I get are no. Most dermatologists are not thinking about this actively. Think about how many patients, those of you in the audience who do see patients clinically, think about how many patients you have that have had breast conserving surgery and radiation for breast cancer. It's very common. So I think it's important that we keep an eye out for this. To hope, you know, there's not proof that early detection improves survival, but I think it can't hurt to detect angiosarc early, and that we've got to start somewhere in helping to fight this disease. So the pitfalls on the pathology side are, of course, a small biopsy with incomplete clinical history is a recipe for the disaster. And so, you know, I always say, you know, pathologists need to talk to their dermatologist if they don't know the clinical scenario for a vascular lesion, especially if it's breast. If I see a vascular lesion on the breast, I almost always will call and get a history. Is there radiation? How big is this? What does it look like? Even if it looks like a benign hemangioma to me, because in the setting of the breast, I'm always extra careful because I know how common it is for patients to have breast radiation. Some forms of hemangioma can look like angiosarc because they can look infiltrative, but looking at the low power picture and also the clinical history are very helpful to sort this out. And Kaposi sarcoma can sometimes mimic angiosarcoma and vice versa. I've seen very spindled angiosarcs that looked almost identical to Kaposi, but like we mentioned earlier, there's a completely different treatment and prognosis. Kaposi is not usually treated surgically. In the setting of HIV, we try to treat the immunosuppression, and you're trying to get their immune status better to fight off the HHV8 infection. But usually big surgery is not indicated, whereas for angiosarc, surgery is the mainstay of treatment. So fortunately, we now have the HHV8 immunostain, which is very useful and can really help you. And anytime you have any doubt about Kaposi sarcoma, just do an HHV8. And if it's negative, it's very, very unlikely to be Kaposi. So I think that's very helpful. But you can have infiltrating vascular channels in Kaposi, so that can be hard. And the other thing is that Kaposi usually does not have the severe nuclear atypia that angiosarc has. But it can sometimes, it just usually does not. All right, and then finally, epithelioid angiosarc looks like other cancers. It looks a lot more like a carcinoma or a melanoma. It can look like epithelioid sarcoma. It can look quite different, and it often expresses keratin. But again, the treatment and prognosis is very different for epithelioid angiosarc versus these entities here. So it's really important to keep epithelioid angiosarc in mind anytime you have an epithelioid lesion that you're not sure how to classify. So here's an example, epithelioid angiosarc. I mean, I don't know about you, but I've seen metastatic melanomas all the time that look very similar to this. But note that blue-gray cytoplasm. It's a really useful clue for epithelioid angiosarc. And these disheesive cells that are falling apart and leaving blood-filled spaces, these are not really well-formed vascular channels, but anytime you see epithelioid cells floating around in pools of blood, think about angiosarcoma. And it's easy. Just do a couple of immunostains to exclude it and to avoid making a huge mistake diagnosis. So here's the problem that I mentioned, though. Epithelioid angiosarc expresses keratin oftentimes, sometimes up to 50% of them can express keratin, just like carcinoma does, just like epithelioid sarcoma. And again, those are very different diseases. And here's an example of CD31, the strong membranous staining that you'd like to see in angiosarc. And you can use other markers like ERG. ERG is a nice nuclear marker for endothelium, and I really like it. I use it a lot. And if you're debating about epithelioid sarcoma, you can use INI1, which will be retained in angiosarcoma and most other tumors, but lost in epithelioid sarcoma. So here's an example of ERG. It's a beautiful nuclear stain. It's very clean and relatively specific, although epithelioid sarcoma can sometimes also express ERG, and prostate cancer often expresses ERG. So there are a couple of other things, but overall I think ERG is a really useful marker. So let's talk about AVL, Atypical Vascular Lesion. So I don't really love this name because this lesion is not really that atypical, and also the name sounds like it's a descriptive diagnosis rather than an actual specific entity name. So I think that confuses a lot of people. And what this is a benign vascular proliferation that arises in the setting of radiation. And it often looks histologically a lot like a lymphangioma or a lymphatic malformation. It has infiltrative growth but lacks atypia usually. And clinically, this is the most important thing about AVL. Clinically, these usually look like small, flesh-colored papules arising within the radiation site, as opposed to angiosarc, which I've already shown you, purpura and large nodules or plaques. So the clinical here is hugely important in helping distinguish between AVL and a subtle angiosarcoma. Here is a picture from Menzel's paper where he looked at AVLs, and you can see this lady has multiple AVLs, and they're all these little kind of almost warty-looking flesh-colored papules on the breast in a radiated patient. They're not the large nodules of violaceous, erythematous angiosarcoma that we would see. So it's really helpful to know that history to make sure you don't mistake the diagnosis. Here's an example histologically. You can see that you have a dermal proliferation of infiltrative vascular channels, and it's going down quite deep in the dermis, actually. And at higher power, look, this is infiltrative channels that are dissecting between the collagen bundles. You can sometimes have a little bit of hyperchromasia in the endothelium, but they do not usually multilayer. They do not usually have mitoses. They do not usually have pleomorphism. So those really atypical features of angiosarc are usually lacking in AVL. But you can have some hyperchromasia, and you definitely can have infiltrative growth. So if I'm in doubt, I call the clinician to discuss, ask what the history is clinically. I think that if you can conservatively excise these, it's probably a good idea just to be sure that you're getting the whole lesion and not missing an underlying angiosarc. But most people think that the majority of AVLs are actually benign and do not progress to angiosarc. So we just talked about all of this, but here it is for your reference. And if you're really debating over angiosarc, this is the great time to use the c-Myc amplification test. So you do FISH, an AVL will be negative for c-Myc amplification by FISH, whereas a post-radiation angiosarc is usually positive. All right, so this is kind of controversial and evolving, but again, most people think these are probably benign. There are rare examples of that are basically proven AVL that turns into angiosarcoma, but most of the time we think that these are probably not precursor lesions. They probably just arise in the setting of radiation just like angiosarcoma does, but most of them do not progress to angiosarc. But the biggest thing to me is I usually will ask the clinician to remove the lesion so that I can make sure that I don't have an unsampled underlying bigger angiosarcoma. I just want to make sure I'm seeing the whole thing. And I do recommend close follow-up for patients with AVL. I think it's a good idea to make sure that they get screened often just to make sure there's no new vascular lesions developing. And sometimes patients have multiple, 30, 40, 50 AVLs. I've not seen that personally, but it's been described. And in those cases, you obviously cannot completely excise all of those. It wouldn't be feasible. So I think just close follow-up for those patients is important. All right, so let's talk about hemangioendotheliomas. And I mentioned earlier that this is a group of vascular tumors that have intermediate malignant potential. I think that's a kind of confusing phrase, but what it basically means is they're not totally benign, but they're not as bad as most malignancies. In essence, local recurrence or regional spread is relatively common for hemangioendotheliomas, but distant metastases and death from disease are relatively uncommon, with the exception of epithelioid hemangioendothelioma. So that's kind of why these hemangioendotheliomas have earned this kind of intermediate status. So, and again, I'll point out that each specific type of hemangioendothelioma is unique in the way it appears, it's unique in the behavior, it's unique on a molecular level. We're now finding that different hemangioendotheliomas have different molecular abnormalities that give rise to them. And so these are just a group of different entities that all share the hemangioendothelioma name. They are not just one disease with multiple different variants. These are all independent diseases. And because of that, you should never, ever use hemangioendothelioma not otherwise specified as a generic diagnosis. So if you have a vascular lesion that's weird and you don't know how to classify it, don't just say, oh, this is an unusual hemangioendothelioma. I think that if we do that, hemangioendothelioma will become a meaningless wastebasket category. And right now it actually serves a useful purpose. So I will only diagnose hemangioendothelioma if it really fits well into one of the described individual types of hemangioendothelioma. So I think it's important not to just use that name as a wastebasket category. All right, so just to hit that home one more time. So the types we're going to talk about today are epithelioid hemangioendothelioma, Kaposiform Hemangioendothelioma, and epithelioid sarcoma-like, also known as pseudomyogenic hemangioendothelioma. And epithelioid hemangioendothelioma is the lung and the liver are the most common sites. And in those locations, there's quite a bit of morbidity and mortality. Many of those patients undergo organ transplant to try to control their disease. It's a very serious disease to have. And a subset of those patients, sometimes up to 50%, will eventually die from their disease. A minority of cases, maybe 10% or so, will occur in the skin and the soft tissue. And in that setting, they tend to be much more indolent and well-behaved than for the organ-based EHEs. But they may still cause mortality. Some of those skin and soft tissue epithelioid hemangioendotheliomas will metastasize and kill the patient. And the other thing that's important to note is that the organ-based EHEs can sometimes metastasize to the skin and mimic a primary tumor. So if I ever see EHE in the skin or soft tissue, I usually will point out that, I can't exclude that this could be a metastasis, and they need to scan the patient and make sure they don't have internal disease. So here's an example of, there's not a specific appearance for this, but this ill-defined nodule with some surrounding erythema and maybe lichenification. So they don't have a very specific appearance clinically, and most patients don't have any idea that they have this, so it's hard to find good clinical pictures of epithelioid hemangioendothelioma. And here's microscopically what they look like when they're in the skin. They are a dermal or subcutaneous nodule, and at higher power, the classic feature are epithelioid cells that are arranged in cords and chains or small nests within this kind of myxoid and sclerotic or mucinous and sclerotic background. And when you see the cells, they have these vacuoles in their cytoplasm, and those are referred to as blister cells. And traditionally, these blister cells will often have little red cell fragments within them, and that's because these are actually, the tumor cells are attempting to recapitulate vascular lumen formation. So these are abortive lumens forming within the cytoplasm of the tumor cell. It's kind of a similar concept to what you might see in, say, lobular breast cancer, which has those abortive little glandular structures that can have secretion inside them. So those are the classic blister cells of epithelioid hemangioendothelioma. But I will point out, you can have vacuoles in lots of different vascular tumors. Any vascular tumor with plump epithelioid appearing endothelial cells can have the tendency to have vacuole formation. So just to point that out, that just because you have a blister cell does not mean for sure that something is an epithelioid hemangioendothelioma. And another important note is that these tumors usually do not make well-formed infiltrative vascular channels like angiosarcoma would. And that's a useful thing to help distinguish EHE from angiosarc. And that's why these tumors originally, when they were described in the lung, people for a long time thought EHE was an unusual form of carcinoma. And actually, my mentor, Dr. Weiss, was the first person to realize that these were vascular tumors and to name it Epithelioid Hemangioendothelioma in 1982. So these can be tricky. They don't necessarily look like a vascular tumor at first glance. And they may also express cytokeratin, just like epithelioid angiosarc. So be very careful, because it's easy to see a tumor like that in the skin. It's keratin positive. It's easy to think that could be metastatic breast cancer or something like that. And so additional immunostains could really help you there. Doing some vascular markers would solve the problem. And more recently, Brian Rubin at Cleveland Clinic and some others have described that there is a translocation in epithelioid hemangioendothelioma, and that's the WWTR1 CAMTA1 translocation, and that's found in the majority of EHEs. And then a small subset will have a different translocation, YAP-TFE3. So you can test for these via FISH in difficult cases. I actually have one right now that Brian Rubin is doing FISH on, because I think it's probably an epithelioid angiosarc, but I just want to be sure it's not an unusual malignant epithelioid hemangioendothelioma, because there's treatment difference for the patient. So that's a useful test in challenging cases to do FISH there. And let's change to Kaposiform Hemangioendothelioma. This is a skin or soft tissue mass that arises in infants, almost always in little babies. Occasionally can be in adults, but be very careful before making that diagnosis there. It can be locally aggressive and have regional mets, but distant metastases is very uncommon, actually. The biggest problem with Kaposiform Hemangioendothelioma is the fact that many of these patients get Kasabach-Merritt syndrome, and this is a consumptive syndrome where the platelets are sucked up into the vascular spaces of the tumor, and the patient gets very low platelets levels as a result, and because of that they bleed. So most of these patients do very well, but about 10% of these patients will die, and when they die, it's not usually because of growth of the tumor itself. It's usually because of the low platelet counts and the bleeding that comes along with that. And as you can imagine, a patient with a platelet level of 5,000 is not going to be a great candidate for surgery to remove a large tumor. So you kind of end up in a very difficult situation where you want to remove the patient's tumor, but they don't have enough platelets for you to be able to remove it. So it's very challenging to deal with clinically. And a related entity is called acquired tufted angioma, or angioblastoma of Nakagawa, if you like eponyms. And this microscopically looks identical to Kaposiform HE, but it's just a small skin lesion in adults, and it's not associated with Kaposiform. So microscopically, tufted angioma looks just like Kaposiform Hemangioendothelioma, but the difference, again, is clinical. So if you're getting the thing here, I think everything we've talked about, the point I'm making is that knowing the clinical, as with all derm path, is really important, but especially for vascular tumors. Many soft tissue tumors in the skin don't have very specific clinical characteristics to help you. So oftentimes the clinical is not very important for some of the other types of spindle cell tumors that arise in the skin and subcutis, but vascular tumors are an exception. The clinical features are often very important to helping you sort out what's going on. So here's a clinical picture of this large violaceous mass in the axilla of a young baby. And microscopically, this is a classic feature. These cannonballs, these whorled nodules of spindled endothelial cells, and they begin to have little compressed slit-like vascular spaces. And it's within these little whorled compressed nodules of vascular channel, that's where the platelets get caught up, and throughout the whole tumor it sucks up all the platelets out of the bloodstream, and that's why the patients get low platelets and develop Kaposiform syndrome. So you have these nodules of spindled endothelial cells and slit-like channels that kind of look a little bit like Kaposi sarcoma, not really, but a little bit. And then you also tend to have dilated lymphatic spaces, which we don't really see here, but you often have dilated lymphatics out to the side. So we just described all of that. It infiltrates into the adjacent soft tissue. So unlike tufted angioma, which is usually confined to the skin, the Kaposiform HE will infiltrate way down into the underlying subcutis and skeletal muscle oftentimes. And the one main differential for this is infantile hemangioma, or cellular hemangioma of infancy, can have areas that look a good bit like Kaposiform Hemangioendothelioma. And if you're ever stuck in that setting, the useful marker is GLUT1. I don't routinely do this, but in tough cases it can be useful. GLUT1 is negative in Kaposiform HE, but positive in infantile hemangiomas. All right. So let's talk about epithelioid sarcoma-like hemangioendothelioma, perhaps one of the longest names in soft tissue pathology. And like Laszlo mentioned, I'm really a big fan of social media. I use Twitter and Facebook a lot, so any of you who are on Twitter, you're welcome to follow me and interact with me there, or on Facebook. But the problem with these long names is that Twitter only allows you to use 140 characters per tweet, and sometimes if I want to tweet about epithelioid sarcoma-like hemangioendothelioma, that takes up over half of the tweet. So it's a real problem in soft tissue if you want to use Twitter because the names are so long. So the other name more recently given to this by Chris Fletcher's group is pseudomyogenic hemangioendothelioma, because sometimes they can have kind of a rhabdomyoblastic appearance. So these often have a very unique clinical presentation, and so yet again, it's an important clue to diagnosis. Epithelioid sarcoma-like HE has a tendency to present as multiple lesions in multiple tissue planes. So what I mean by that is the patient will come in and they'll have a couple of skin nodules, and then if you do a scan, you'll find that they not only have skin nodules, but they have nodules in the subcutis, and in the skeletal muscle, and in the bone of their whole leg, for example. So that's the classic presentation of this tumor. It's not usually just one nodule. The clinical appearance is very worrisome for metastatic disease because you have all these additional nodules in the soft tissue and the bone, and they'll oftentimes the clinicians or the radiologists will be very worried that this is metastatic from somewhere. So histologically, though, this tumor looks a lot like epithelioid sarcoma, and sometimes can also mimic rhabdomyosarcoma. So those two things explain why it has been given the names it's been given. In Dr. Weiss's initial study with Steve Billings and Andrew Fulp in 2003, when they first described this, all of the cases in their series had all been sent into Dr. Weiss for consultation, and they were all called epithelioid sarcoma. So I think that I really like this name because it hits home the importance of not confusing this tumor with epithelioid sarcoma. Epithelioid sarcoma looks similar and has similar staining, but is much worse in its behavior. Okay, so immunostains will solve the dilemma though if you're savvy and know to look for it. So keratin is positive in this tumor, just like epithelioid sarcoma, but also CD31 and ERG and FLI1 vascular markers are also positive here. These markers would be negative, well, CD31 would be negative in epithelioid sarcoma. ERG is sometimes positive. And then CD34, interestingly, even though this is a vascular tumor, it tends to always be negative for CD34. And INI1, which again is lost in epithelioid sarcoma, is actually retained in epithelioid sarcoma-like hemangioendothelioma. And Desmond is negative, and so you can use that to help sort out and exclude rhabdomyosarcoma. So I think doing a panel here that includes keratin, 31, and INI1 will really help you sort out what this is versus epithelioid sarcoma. And it may be locally aggressive, but it's so far in the cases described in the literature, there have been, I guess, somewhere between 100 and 150 cases now reported in the literature. I think there have only been 1 or 2 cases that had distant metastases and death. So this is very aggressive locally, has multiple regional metastases, can be a real management problem, but does not usually kill the patient, unlike epithelioid sarcoma, which over 50% of the patients will eventually get distant metastases and die from their disease. So the prognostic difference here is very important, it's very big, and it's really important to not confuse this tumor with epithelioid sarcoma. So I apologize, the pictures are a little bit washed out here. I need to do something about that. I'm sorry. You can see here these kind of plump spindled cells in fascicles that have very dense pink cytoplasm. And in areas, the fascicles, you can still see the fascicles, but the cells become very plump and have abundant cytoplasm that's very dense and pink. So that's very similar to the kind of cytologic feature that you would see in epithelioid sarcoma. And they can make these sheets of very epithelioid cells. So if you take a picture of that and tell me it's in the soft tissue and it's keratin positive, yeah, absolutely you could think about this being epithelioid sarcoma. So it's really important to keep that in the differential. And here's another picture of it. And here, for comparison, is an example of epithelioid sarcoma. And you can see that very dense pink cytoplasm, kind of pale nuclei. So it's really hard to tell these apart just on H&E appearance sometimes. Here's another, going back to epithelioid sarcoma-like hemangioendothelioma. You can see the cells sometimes become very have very abundant pink cytoplasm that displaces the nucleus, and so can have a kind of rhabdoid or rhabdomyoblast-like appearance. But again, a simple Desmond immunostain will easily exclude the possibility of a myogenic tumor here. And they do always express cytokeratin. By definition, I think 100% of them are keratin positive. So really easy to get this confused with a carcinoma or something as well, especially if they're sending this in as rule out metastases. You can see cytokeratin will be expressed, but they will retain INI1 nuclear staining. So the tumor cells are still INI1 positive, like all normal cells are supposed to be. And so this is the most important thing to help you exclude epithelioid sarcoma. Epithelioid sarcoma almost always has loss of nuclear INI1 expression, but this tumor has it retained. So that's a very useful stain. So if you're not using INI1, that's it's a good stain. I use it in practice a lot whenever I'm thinking about epithelioid sarcoma. And there are a few other tumors now that have been described that also have INI1 loss. Most of them, though, do not involve the skin. All right, so here's a paper that I wrote with Lauren Stewart, one of my fantastic co-residents at Emory University when I was a fellow there. And we had this patient that came in with dermatofibromas, is what they were called clinically. And you can see these look a good bit to me like a dermatofibroma. The patient had several of them. But when they did a PET scan on this patient, they found numerous nodules, not only in the skin, but in the subcutis, in the muscle, and in the bone, just on his left leg. So this is a great classic example of how this tumor, epithelioid sarcoma-like hemangioendothelioma, will present. Multiple nodules within one region. And this is just a classic presentation. And again, from our case, we had some rhabdomyoblast-like cells that were in there as well. So now I mentioned several types of hemangioendothelioma, but what about spindle cell hemangioendothelioma? What happened to that tumor? Why did I not mention that? Well, let's talk about that briefly. This is a very interesting story and a tumor that I really like. So again, Dr. Weiss, I know I talk about her a lot, but she was a huge role model for me and very much influenced the pathologist that I am today. And also she described the vast majority, I think, of the vascular tumors that we're talking about, or she has written landmark papers on them. So in the 1980s, she described spindle cell hemangioendothelioma, and these were multiple regional nodules of tumor. and it was thought that they had regional metastases, and that's why it was considered to be kind of a hemangioendothelioma or a low-grade variant of angiosarc. But what happened is that she came back 10 years later, and they re-examined those patients and some others and found that these patients did not develop any new lesions, any distant metastases, no one died from disease. So based on that, they felt that maybe it's better to call this thing a spindle cell hemangioma. This is a benign lesion maybe, rather than a hemangioendothelioma. It's just multifocal rather than having regional metastases. So because of that, spindle cell hemangioendothelioma no longer exists. It does not exist as an entity, and you should never use that name in practice anymore. It is an obsolete term. What we now call them is spindle cell hemangioma. So you get the thumbs up to call it spindle cell hemangioma. And they're important to know about because they are sometimes seen in Maffucci syndrome. And Maffucci syndrome is the coexistence of spindle cell hemangiomas plus multiple enchondromas, or benign cartilage tumors, of the bones, particularly the small bones of the hands and feet. And usually it's very clear clinically that patients have Maffucci because they have deformity of their hands and feet because of these numerous enchondromas. So it's not really important to point out that a spindle cell hemangioma might be associated with Maffucci. Usually clinically they're going to know the patient has Maffucci's already. And most spindle cell hemangiomas are sporadic and not associated with Maffucci. Maffucci is very rare. I've only seen one case of it personally in my career so far. So, and the important thing, though, about Maffucci is they have a risk of developing chondrosarcoma from their enchondromas. Enchondromas of the hands and feet usually do not give rise to chondrosarcoma, but in Maffucci syndrome, they often do. So this is Maffucci, and you can see these nodular deformities of their entire hands. And here again, you can also see some spindle cell hemangiomas in here, as well as these large multinodular enchondromas with calcifications on the X-ray. And here's another example. So here's what spindle cell hemangioma looks like microscopically. And actually, I think these are really beautiful tumors that are very easy to diagnose because at low power, you see two zones. One area looks just like a cavernous hemangioma, big dilated cavernous spaces that looks very similar to cavernous hemangioma or a cavernous venous malformation. And then the other area is more cellular and looks a little bit like Kaposiform baby, so kind of spindled and epithelioid cells in compressed areas. And from this power, note this is a little blood vessel. We'll come back to that in a minute. This is a really useful finding. See, here's a closer view from elsewhere in the tumor. The tumor often grows out of, or even in the lumina of, a large blood vessel. And so that's the theory as to why it's multifocal, is that it kind of grows along inside blood vessels, and that's why patients can have multiple lesions. And if you look, this area, like I said, looks very similar to cavernous hemangioma, but the cellular area is very spindled and also epithelioid cells. I think that people often don't notice the epithelioid cells because the name says it's a spindle cell hemangioma and doesn't talk about the epithelioid nature of the cells. But I think the epithelioid cells are very useful finding. And there are little compressed, almost slit-like blood-filled spaces. So if you're having a bad day, you could think of Kaposi's sarcoma here. It could look a lot like that. So you can do an HHV8, which will help you and will be negative here in this tumor. And the other thing that's really helpful is this. This is a very unique finding. Remember how I told you earlier that vascular tumors with epithelioid-looking endothelial cells often develop cytoplasmic vacuoles? Well, here in spindle cell hemangioma, you have a tendency to get so many of these little vacuoles that they compress together and they look almost like little miniaturized adipocytes. They remind me of like little compressed fat cells. These are not actually fat. These are all vacuolated endothelial cells, but they have this almost compressed adipocyte or miniaturized fat cell appearance. And I think this is very characteristic. I usually can find at least some areas in spindle cell hemangioma that look like this. Most cases that I've seen have this, and I've never yet seen this exact look in any other vascular tumor. So I think, to me, that this is a relatively specific finding. It's very useful. So keep that in mind. It's a nice clue. All right. The other thing that spindle cell hemangioma can have is you can have these large thrombi that have a tendency to calcify, and so these are called phleboliths. And you can even see these on X-rays, on imaging. You can see these little calcified foci within the spindle cell hemangioma. And recently, Alex Lazar from MD Anderson and a big group of other people described that IDH1 and IDH2 genes are often mutated in spindle cell hemangioma, both in sporadic cases and Maffucci-associated cases. So there was some debate for a while if maybe spindle cell hemangioma was actually a sort of malformation, but now because of this mutation, I think that's pretty solid evidence that we're dealing with a true neoplasm here. So I don't use this routinely to test, but I think it's an interesting scientific finding. All right, and then let's just touch on two unusual hemangiomas, and then we'll have time for a few questions. This, for those of you who have seen this, you recognize it almost instantly. But if you've never seen this lesion before and don't know about it, you might really struggle with what this infiltrative-looking lesion that has little vascular spaces infiltrating between collagen bundles into the deep dermis. You might struggle and think that this is Kaposiform or some sort of malignancy because it's infiltrative growth. Looking closer, you can see that there are kind of spindled cells here and very thin, almost slit-like compressed vascular channels. Here's a closer look, kind of spindly again. There certainly is some features here that can be reminiscent of Kaposiform. You have almost no atypia, very few mitoses, and usually the blood is confined to the little vascular spaces, and you don't usually have much extravasation of red cells or a hemosiderin deposition like you would have in Kaposi. Here's another look. So this is a microvenular hemangioma. So it's an unusual variant of hemangioma. It's totally benign, but because of its infiltrative growth and slit-like channels, it can mimic Kaposi sarcoma. And so the things that we talked a little bit about there are some variety of features that can help you distinguish it from Kaposi. If you have any doubt, just do an HHV8 immunostain and that will sort it out. But I find the lack of extravasation of red cells, the lack of mitoses, which Kaposi almost always has mitoses, and also the lack of inflammation in plasma cells. Kaposi almost always has plasma cells, and microvenular hemangioma usually does not. And again, the clinical history and appearance are very helpful in sorting this out too. Kaposi has very unique clinical appearance or scenario as opposed to this tumor. So microvenular hemangioma is benign, but can get confused with Kaposi sarcoma. All right, let's look at another unknown, unusual hemangioma. Here we have multinodularity, a very lobulated lesion, and there's a large component of round blue cells in the background. And these round blue cells are lymphocytes, and there are clustered blood vessels with very thick, plump endothelial cells. And in some areas, they almost look solid. If you might have trouble distinguishing that as a vascular space because the lumen can be so compressed by the size of the endothelial cells. And of course, in the background, you have lots of eosinophils. So many of you already know that this is angiolymphoid hyperplasia with eosinophils, or epithelioid hemangioma. But when you have a small biopsy of an area that looks like this, it can be very challenging because the cells are so epithelioid and plump, and you might have trouble recognizing vascular spaces. So you can get concerned seeing that maybe you're dealing with an angiosarcoma or something worse. And again, the cells have an epithelioid appearance and tend to kind of push in and hobnail into the vessel lumen. I don't like to use the word hobnail too often because it's too much of a buzzword. It confuses people. But you can have hobnailed looking cells in many different vascular lesions, so don't get too worried about that. But they tend to push into the vascular lumen like that. And sometimes the inflammation can be relatively sparse, and sometimes eosinophils are very scarce. And so in cases like that, when you don't have much of the infiltrate there, it can be challenging to make the diagnosis. And oftentimes, this lesion will arise from a damaged blood vessel, particularly the temporal artery. So the temporal region of the head is a very common site for this, and oftentimes, if you're lucky, you'll find a damaged, thick-walled vessel from which the proliferation is growing, and that's a useful clue to the diagnosis. And here's the vessel wall. Here's the kind of proliferation within the vessel, and then extending outside the vessel here. So this is the term that I like to use is epithelioid hemangioma. In dermatopathology, we often call it ALHE for angiolymphoid hyperplasia with eosinophilia. And we talked about all of this already, but you can review it again later. One thing I'll point out, we don't have a picture of it here, but the penile type of epithelioid hemangioma can look very cellular and atypical and can easily get confused with angiosarcoma. And for obvious reasons, it's really important to not misdiagnose angiosarcoma on the penis because it can result in irreversible, terrible surgical complications. So very important to know that if you see a weird vascular lesion on the penis, always consider the possibility of an epithelioid hemangioma that's looking atypical because of its unique subtype there. So that's an important lesion to be aware of. And then some other hemangiomas, there are several other types that can mimic Kaposi sarcoma, like sinusoidal and anastomosing. We don't really have time to go into those. So I think that brings us to the end of the lecture. I appreciate your attending and paying attention. This is my email address. If you have any questions, feel free to email me. If you use Twitter, this is my Twitter name. And I'm also on Facebook. So you can contact me through basically any social media channel. And I keep a list of all of my online educational resources on my website, pathinfo.wikia.com, and under my user profile, you can find links to all of the different things that might be of interest to you educationally. And I do have 2 Facebook groups. If you're on Facebook and haven't joined these yet, feel free to join. One is a dermatopathology Facebook group, and the other one is focused on bone and soft tissue pathology. There are about 15,000 members in each group, so there are numerous cases that are shared on there all the time, and it's a really great way to learn, I think. So thank you again for the opportunity to speak, and thank you, Laszlo, for inviting me, and I'll be happy to take any questions now.
Jerad, thank you so much. It was absolutely fantastic. I think everyone enjoyed it. There are actually a couple of things. Question-wise, Martina had a very good question that in case of the epithelioid hemangioendotheliomas, have you tried to use the TFE3 immunohistochemical staining?
No, that's a good question, Martina. I've not tried to use TFE3. The YAP TFE3 translocation is only positive in a small subset of EHE. So I imagine that it would work, but only on the ones that have that translocation. So I've not tried that yet. I'm assuming that's actually been tried by someone, but I can't recall having read it. I'm sure that it must have been tried. So, but I have not used it personally. Good question.
My question on this, until others are thinking, that do you see actually a difference with these 2 type of translocations? Because TFE3 usually associated with a very epithelioid appearance, like alveolar soft part sarcomas, the very typical appearance in case of the kidney cancer associated with TFE3 mutations. Do you see, or those who describe these entities, do see morphological differences between the 2 types of EHEs?
Yes, I believe that has been described. I've actually never seen one of those cases yet in person. They're relatively uncommon, but they are described to have unique features, and I think those go along with the TFE3 associated features, like you said, that have been seen in renal cell and ASPS and other types of tumors that are TFE3 associated. So I believe there are features that can hint at the fact that you may be dealing with one of those translocations rather than the typical WWTR1 CAMTA1.
Okay. Eugene has a very good question. Is non-HIV advanced African endemic type Kaposi being considered for intermediate category, or do those patients die from their disease?
That's a great question. So usually the Kaposi is a little bit of a hard disease because there are different clinical subtypes and they behave differently. So the typical elderly type or endemic classic form of Kaposi, the classic form in elderly males, that tends to be very indolent. The HIV-associated form tends to be quite aggressive and disseminate and get organ involvement, and those patients sometimes die from their disease or from the sequela of HIV and AIDS. And the African form is kind of in between there. It tends to be slowly progressive over time, but eventually can spread to nodes, and once it gets into the nodes, it tends to be more aggressive. So I think that yes, the African form can behave in a more malignant fashion, but I think that's the kind of take-home point of the intermediate malignant potential tumors. Is there tumors that oftentimes don't behave badly, but sometimes do. So I think in the setting there, the stage of the disease for Kaposi's really is important. Once you get nodal involvement, there's a significant chance that maybe the patient will have more aggressive behavior. Once you get organ involvement, definitely you have to be concerned that it's going to behave aggressively. Okay. Oh, and I see a question here also about erector pili infiltration in microvenular hemangioma. I have never seen that. Maybe it happens, but I've never seen or noticed it, at least. That's a great question.
And there is another from Dr. Souza for atypical vascular lesions on the breast. You mentioned that you like to have them excised. Are margins problematic in patients that has multiple lesions? Sometimes they appear to be closer clusters. Any tips? Is imaging helpful?
Yeah, I think margins are challenging on any vascular lesion that's not very atypical because blood vessels are normally seen in all tissue, of course. I think that the patients that have multiple AVLs, atypical vascular lesions on the breast, those patients are always problematic because if you have multiple, like Dr. Weiss told me that there's just not any feasible way aside from doing a mastectomy to remove all those. And because they usually are benign, it probably does not make sense to aggressively treat them surgically. But when they're solitary or few, all of the ones I've seen in practice so far have been solitary actually. When they're solitary, I think it's a good idea to excise them. But Dr. Weiss told me that she believes that they don't have to be excised, that it's not required to excise them. I just think because it's a relatively newer entity, because there's still some debate over how often they may give rise to angiosarcoma. Most of them probably don't, but we're not 100% sure. Because it's new and kind of an evolving area, I think it's good to be kind of prudent and kind of cautious clinically as far as follow-up goes and as far as surgical resection goes. So I think if it's clinically feasible to remove the lesion, that's great. And so far, the couple cases that I've had, I didn't have really any problems with margins. I thought it was pretty easy to see where the lesion ended, but I can imagine that it could be challenging. So I guess if you have a bigger excision and the margins are still positive, then that maybe should make you start wondering, especially if they're diffusely positive, that maybe should make you start wondering, gosh, is this something worse? Because usually once they've done an ellipse around it, it should be more or less out because usually AVLs are small lesions. There's another question here about, is Mohs appropriate for any vascular malignancy? That's a great question, and I'm not actually entirely sure of the answer. I do know of people who have used Mohs to treat angiosarcoma, and I don't know if there's any good data to face wide local excision typical surgery against Mohs. I'm not sure if there's been studies like that done, probably not large ones. And I think that with malignant vascular lesions, the problem you run into is regardless of the modality of surgery that you use, local recurrence is still an issue because the lesions are often all in the vascular system, and so they can easily pop back up as satellites. So I think it's possible to use Mohs, but you just have to really consider each individual situation and what the best surgical approach is on a case-by-case basis. And let's see, Tiberio asked, said that he has seen erector pili pseudo-infiltration in microvenular hemangioma due to tangential cut. Thanks for that comment, Tiberio. That's great. I'd love to see a picture of that. That sounds very cool. And another question from Martina, should incompletely excised AVL that do not have adequate information about the clinical context, should MIC, immunostain, or FISH always be done? I don't think it's required. I think that you should just make a comment accordingly. Usually in my practice, I will call the physician if I have an AVL to explain to them, hey, this is an unusual, weird thing, because otherwise when a dermatologist who may not be familiar with that lesion gets a report that says atypical vascular lesion, it sounds like I'm hedging, right? It sounds like I'm making some kind of waffly diagnosis where I don't know the answer. And so I actually have a kind of long comment in my template for this tumor that I say this is a specific entity, it arises post-radiation, and I kind of explain everything. But usually I just get a hold of my clinician and find out what the clinical context is. So I do not routinely use MIC in my practice, but it has been described by people as being useful. And I know Steve Billings, who is one of the people who's done research with using MIC on these, he tends to like it for cases that are challenging. So it's a possibility, but I don't think it's a requirement to do, no.
Great. So it was a very entertaining talk. My very last question, if you don't mind, that I think that most of the problem with vascular tumors, especially the malignant ones, are due to the advanced stage of the disease. So usually when those patients get the diagnosis, they already have a large area involved. Now, what do you get, or do you get any advice related to that from the support groups? What is the patient's advice? How do they diagnose themselves, or do they have signs about, or any advice to other people for early diagnosis?
Yeah, so that's a great question. And I think, I've been working with patient support groups on Facebook for about a year now. I started with a DFSP support group, and now I work with Angiosarc, Epithelioid Hemangioendothelioma, and about a dozen others, I think almost. And I think that there are some fantastic pearls of wisdom that these patients have. They often have pictures of how their lesion started and how it progressed and grew. Some of them keep very detailed diaries and document what it looked like after treatment and before treatment. And those things are a wealth of information for the setting of patient education. And I'm actually currently working on getting some research projects together that will try to harness some of that information and make it more available to other patients and also to medical providers. And I think in addition to signs and symptoms, oftentimes patients that join these groups already have been diagnosed, and they sometimes already have advanced disease, unfortunately. But the other thing that's really helpful is regarding treatment. A lot of times a patient with a rare sarcoma like angiosarc, they may be seeing someone at their hospital. Their oncologist may have seen one angiosarcoma before, so they may not have a lot of experience. But through the support group, other patients will tell them, oh, this doctor is who you should see if you want to go to MD Anderson. This doctor is who you should see if you want to go to Sloan Kettering. I was on this drug regimen, and then they switched me to this chemo, and here are the side effects. These patients have very detailed information about the different types of therapies available, how they responded, and many of them are much more savvy than most medical providers because they spend a lot of time researching the disease. When you have a deadly disease, it's amazing that it really drives you to learn a lot about it. And so I've learned an enormous amount from working with these patient groups. I started to try to give them some information and explain the pathology side of things to them, which they've appreciated and been very thankful for. But the benefit to me has been enormous because I've learned so much from the patients about their own disease, and it's really changed the way that I view a lot of these diseases in my practice, actually. So it's been a fantastic experience to work with patient support groups this way.
Okay, well, thanks, Jerad, again, and thank you, everyone, for being active and asking questions. I think that it was a fantastic event, and we look forward to all the visitors that Jerad basically tweeted and disseminated the link. And I'm also going to put it here that derm talks at gmail.com. So this is the, oops, I wanted to send it to everyone. So dermtalks at gmail.com is the site or is the email address where you can email us, and then I will be able to put you on the list for the mailing list, and everyone could enjoy this talk later on also, because we are going to make a recording of it. So with all that, thank you again, Jerad, and a very good night to everyone.
Great, thank you.